Everyone is able to see my screen. I hope the screen is visible to all.
It's clear, ma'am.
Yes, ma'am.
Yeah. So whenever we are discussing something about neuroanesthesia, I learned from madam that many of the students have joined this webinar. So whenever we are dealing with neuroanesthesia, this is one of the most important subspecialties of anesthesia, where the anesthesiologist plays a very vital role in managing these cases. And whatever we do during anesthesia or in the perioperative period, right from pre-op till the patient is shifted to ICU, and also later on, the fate of patient, the mortality, morbidity of the patient depends very much on our role in the perioperative period. So we should know what problems can occur while managing these cases, and also we should know how to deal with the commonest challenges that we face when we anesthetize these patients in day-to-day clinical scenarios. Yeah. So as an anesthesiologist, we are dealing commonly with traumatic brain injury patients who come to our emergency department with either a big extradural hematoma like this, or a subdural hematoma like this, or bifrontal contusions like this with variable Glasgow Coma Scale score. As a PG student, you must know what is Glasgow Coma Scale score. So once you see the patient, you will be able to distinguish the patient, whether it's a mild head injury, moderate head injury, or a severe head injury. We can get patients with Glasgow Coma Scale score less than 8. It is called as severe head injury. And such patients, we need to intubate and ventilate these patients whenever we see them in the emergency department. And every patient of traumatic brain injury, we have to consider that their cervical spine is unstable unless clinically and radiologically the fracture of cervical spine is ruled out. So that also we have to keep in mind. Neuroanesthesia is very vast. It is very difficult to cover all the important topics in one lecture, but definitely today we will discuss the challenges that we face in commonest neuroanesthesia cases that we do in our day-to-day practice. Another cases which we commonly do are various brain tumors. The brain tumors can be difficult like cases like CP angle tumor like this, in which the position matters a lot because usually surgeon gives a park bench position, or the tumors like can be supratentorial or infratentorial. Sometimes we get to deal with some vascular tumors like meningioma. And why we should know about these tumors? That is because we will plan our anesthesia management depending upon seeing at the location of the tumor. We will discuss it later on. We may get massive hypertensive intracerebral bleed with midline shift and mass effect. So these patients can come for emergency craniotomy with a blood pressure of 220 by 120, and the surgeon will ask us for emergency decompressive craniotomy, and we need to anesthetize such patients in a short period of time after optimizing these patients. Another cerebellar hemorrhage. It can be traumatic or it can be vascular also. See, this is the space where it is called as a brainstem, very important medulla oblongata, brainstems, very vital structures are here. And there is very less space here. So something accumulating here, it may be a clot, a tumor or anything. It will cause compression of brainstem, and then this can again come as an emergency to our team, anesthesia team, and we need to anesthetize these patients in an emergency. Something like subarachnoid hemorrhage, aneurysm clipping, that also can come as an emergency. And many of the neuroanesthesia cases which we are practicing in clinical scenario, we get very little time to optimize, and we have to do them on an emergency basis, except the tumors of the brain tumors. So many of these other cases, we may have to take them and optimizing in a short period of time. We do get pediatric cases like this, a very large, huge hydrocephalus, encephalocele like this, a meningosmilocele like this, and here we need to use the concepts of both pediatric anesthesia, neonatal anesthesia, as well as neuroanesthesia. So what are the commonest challenges we face in neuroanesthesia? This word, when I was a PG student, What is cerebral perfusion pressure? This word is very confusing for all of us, because practically we are not monitoring cerebral perfusion pressure. What do we monitor? We don't monitor even ICP also, but we monitor our mean arterial pressure. And we have to maintain the hemodynamic stability throughout our neurosurgical case so as to maintain the cerebral perfusion pressure. We have to, and why this is important? It will prevent secondary brain injury. We have to take control of intracranial pressure by having a control over mean arterial pressure. At the end of the class, somebody is going to tell me the equation about cerebral perfusion pressure, the relationship between the cerebral perfusion pressure, intracranial pressure, and mean arterial pressure. And then we will understand why mean arterial pressure is important, because we are not monitoring cerebral perfusion pressure. In very few cases, we monitor intracranial pressure, but what we are monitoring is the mean arterial pressure, the blood pressure of the patient. And why this is important? This will prevent a secondary brain injury. We do get cases with difficult airway, and this is very challenging. It may not be only cervical spine. Even an unconscious patient or drowsy patient with less mouth opening because of tobacco chewing, and it is very difficult to assess such kind of patients when we anesthetize these patients. Surgeons request us to relax the brain during surgery, so it is very challenging for all of us to give a proper surgical feel to the neurosurgeon. A vascular tumor, we have to be prepared for blood loss management. Then fluid and electrolyte disturbances can occur because these patients are on diuretics, anti-edema measures like mannitol. So we need to take care of fluid and electrolyte disturbances. We need the patient awake at the end of the surgery to assess their neurological status. So we want to have a rapid recovery at the end of the surgery. We need to control their pain post-operatively. We do get many elderly and comorbid patients to manage, and a most fundamental thing is to give them proper neuroprotection by maintaining their cerebral perfusion pressure. So in next 20 to 25 minutes, we will see many of these major challenges which we deal in neuroanesthesia. So the cornerstone of neuroanesthesia is to have a balance of intracranial pressure-volume relationship. But what is important for us? These words are difficult. What is important for us as an anesthesiologist? What is in our domain? What is in the domain of an anesthesiologist is to maintain cerebral blood flow, to avoid increase in the cerebral blood flow by any means. This is why it is important. If there is an increase in cerebral blood flow, it will increase the ICP, it will cause brain edema, and it will cause, again, recovery of the patient may not be that good. So what is in our domain? We have something, our anesthetic drugs. Drugs like inhalational anesthetic can increase cerebral blood flow. Our mean arterial pressure monitoring and regulation. We have to monitor mean arterial pressure very judiciously. And why? This is important. If there is hypertension, it will cause brain edema. And if there is a hypotension, it will cause cerebral ischemia. So we need to monitor mean arterial pressure judiciously. We have to avoid hypercarbia. Again, why hypercarbia? This is because if there is a hypercarbia, it will increase the cerebral blood flow. And we have to avoid hypoxia. This is why, again, important, because it will increase the cerebral blood flow. So all these things are in our domain. We anesthesiologists are managing various drugs. Various monitors are there to tell us about hypoxia or hypercarbia, and we have to monitor judiciously the mean arterial pressure. So our main goal is to maintain hemodynamic stability throughout the patient. And for this, the care starts right from the pre-operative period. So whenever you see a patient, whether it is an emergency neurosurgery or elective neurosurgery, we need to ask few specific questions to the patient. Did the patient get convulsions? If yes, what kind of convulsions did he got? Whether they were generalized or tonic-clonic? How frequently he got the convulsions? When did he had convulsions last time? And was it hospitalized that time? And how he was treated? So many times patient might give us history that the tumor was detected Why? Because the patient got convergence. It caused the convergence led to respiratory depression, and he needed intubation and ventilation also. So this history is to be asked in detail. We need to ask history suggestive of raised ICP like headache, nausea, vomiting, blood vision. We need to ask history suggestive. This can be given by the relatives where there is a decreased level of consciousness, excessive sleep. This needs to be asked in detail. We need to see also focal neurological signs or ask history suggestive of hemiparesis, sensory deficits, and cranial nerve deficit. After a detailed history, along with our routine history, this history is very specific to a neurosurgical anesthesia. We need to assess the mental status, the Glasgow Coma Scale. We need to see for papilloedema. We need to see for whether there is a hypertension associated with bradycardia, a sign of Cushing response because of raised ICP. We need to assess the pupil if the patient is drowsy with Glasgow Coma Scale less than 8 on ventilator. We need to see or assess the pupillary size. We need to find out if there is any speech deficit or not. We need to find out Glasgow Coma Scale scores. We need to assess even bulbar lower cranial nerve palsy, bulbar palsy. Patient might give you history that there is difficulty in swallowing the food, or there is he gets excessive cough when he drinks water. So this also indicates that there is a lower cranial nerve palsy. This is very important in patients with CP angle tumor. And we have to be prepared for this because extubation at the end of surgery depend on these clinical signs and symptoms. Along with other medications for comorbidities, we need to ask history about steroids and also very important history regarding anti-epileptic drugs. What drugs the patient is taking, because we need to continue these drugs till the day of surgery. We need to give the drugs in the morning of surgery. Next important examination is examination of CT scan and MRI. I will tell you all, this is very important examination as far as neurosurgery is concerned. The examination of CT scan and MRI, I know it is difficult to recognize everything, but you have your neurosurgical team along with you. You have to learn how to read CT scan and MRI. This is very important from anesthesia point of view. Why? You know the size of tumor. You know whether the tumor is placed, whether it is in the silent or eloquent area, whether it is engulfed by a major vessel, whether it is a very vascular tumor, whether there is a midline shift, mass effect, temporal lobe herniation, whether there is a hydrocephalus, whether there is a CSF space around brainstem or not, then whether there is a brainstem involvement. If the patient is undergoing repeat chemotomy, then there is any pneumocephalus. Pneumocephalus means the air has, because of previous surgery, the air has been introduced into the brain, which is compressing the brain matter. And so this examination with the discussion with the neurosurgical team is very important, because the size and location of the tumor will tell you everything. How big is the tumor? What position the surgeon can plan the surgical excision? On which hand you are supposed to take the venous cannulation? So many things that can be dealt with if you know something about the tumor, and also it will guide us regarding the tissue type of tumor. If it is a vascular tumor like meningioma, you need to be prepared with multiple blood transfusion. You need to be prepared with massive blood loss in such kind of patients. So there can be challenges during induction of anesthesia. You might get hemodynamic instability and you might get difficult airway. So the hemodynamic management should be very precise. Why? Again, I will tell you, we have to maintain this word, remember, cerebral perfusion pressure. This CPP has to be maintained, and we have to avoid hypotension and hypertension. So we have to individualize the blood pressure targets instead of fixed mean arterial pressure values. And how you will know the blood pressure targets for an individual person? You must know his preoperative blood pressure levels. I request all of you, when you see the patients in the preoperative period, just don't go on the notes. You check the blood pressure yourself, and you know what is the baseline mean arterial pressure. So you can, patient might be a hypertensive individual. He might be having a high blood pressure. So you need to individualize his blood pressure targets. We need to follow the goal-directed fluid therapy. Invasive arterial waveform may be needed in few patients, like vascular tumor, bleeding aneurysm, massive subarachnoid hemorrhage, a very big tumor compressing the in the posterior fossa. So many cases we need to put arterial, intra-arterial, the invasive blood pressure monitoring, and the clinical benefits of this, that there will be reduced secondary brain injury. See, primary brain injury is not in our hand, but we have to avoid the secondary brain injury. We have to give better cerebral oxygen delivery, and it all will go for improved neurological outcome. So we as an anesthesiologist are playing an important role in improved neurological outcome of the patient, and that is very important. So why difficult airway? There can be a patient factor or procedural factors. So what are the patient factors? It is very difficult to assess these patients, especially in emergency situation. You may get an uncooperative, irritable patient. It is difficult to communicate with them. They may not be able to open mouth for Malampati assessment. They may not be able to sit at eye level. They may not be able to protrude their tongue. They may not be able to do the upper bite taps. There may be difficulty in head and neck mobility. There may be maxillofacial trauma in trauma cases. You may be finding it difficult to give them optimal pre-oxygenation because of maxillofacial trauma. They may have problems in swallowing. There may be decreased laryngeal reflexes. So all these things are very important, and these you may get surprises on table that mouth is not opening because the patient is having trismus because of tobacco chewing. So we need to assess the airway it is very important, especially in a drowsy, unconscious patient, and you need to be prepared for difficult airway management in every patient. What are the procedural factors for difficult airway? We go for awake craniotomies for tumors in eloquent areas. So airway is not accessible in such situations. Then various surgeries like transsphenoidal surgery, stereotactic biopsies, patients with cervical hollow. We are so much away from head and airway, and patients, usually the stereotactic surgeries are done under sedation and local scalp blocks. So here also these procedural factors can make the intubation difficult, and therefore we have to get prepared for our difficult intubation in every neurosurgical case. We may be called to give anesthesia in CT scan, MRI, and angiography suite, and there also we might face difficulties, and we need to assess every patient the way we assess the other patients for airway assessment. So remember that hemodynamics, hypoxia, and airway are very relevant in neuroanesthesia, and if you manage these 3 points, but good hemodynamics, avoid hypoxia, and adequate assessment of airway with managing the airway efficiently, these are the challenges in neuroanesthesia, and you will avoid many important complications in neuroanesthesia. So airway management in neurosurgical patients definitely requires expertise. We need to induce a patient smoothly, and we have to maintain the patient with hemodynamic stability. And why this is important? Even brief episodes of hypoxia, hypercarbia, as well as hypotension can be deleterious to the neurosurgical patient, increasing the morbidity and mortality. Any factor that causes rise in blood pressure can cause intracranial hypertension, and many patients like unstable cervical spine, skull-base tumors, patients of pituitary tumors, acromegaly patients with pituitary tumors, we need to be very much careful about the airway in such patients. So routinely we should start using video laryngoscopes. Video laryngoscope in a ASA grade 1 patient with good Malampati grade 1 patient will always help us in that learning curve. We should have provisions to provide extra oxygen if required. Then we should be updated ourselves for a difficult airway algorithm. The aim is avoid hypoxia, and we should have higher first pass intubation success without any pressure responses at the time of intubation. What are the challenges that we can face during maintenance of anesthesia? Patient might get seizures. Patient is brought from the emergency department to the OT for induction. It is a big extradural hematoma, and before you induce the patient might get convulsions on table. So this you have to be prepared for such kind of complications. Patient may get severe hypotension or even hypertension because of light planes of anesthesia, and hypotension because of these for drugs, propofol, which we are commonly using for neuroanesthesia, that can also be hazardous if there is hypotension. Patient can get brain swelling. The surgeon will tell you frequently, the brain is tense, do something, I want the brain to be relaxed more. This is because with tense and tight brain, it is very difficult for the surgeon to manipulate or to remove the extra additional tumor or blood clot, whatever is there in the brain. And therefore, this is a very important complication that can occur intraoperatively. And in next few slides, we will see how to manage this brain swelling. The patient might get bradycardia, trigeminocardiac reflex if there is stimulation of trigeminal nerve. Venous air embolism is an important complication. Sudden fall, especially in posterior fossa surgeries, sudden fall in EtCO2, sudden hypotension, you must suspect, especially when the dura is exposed and the veins are open and the surgeon is dealing with a tumor. So that time, if you get such complications, then venous air embolism, your patients might need massive blood transfusion. And if you are practicing awake craniotomy for a tumor in an eloquent area, then intraoperatively, because of handling of some important neurological motor fibers, patient might develop intraoperative neurological decline. He may become drowsy, and in those cases, you need to have a control over airway. So first thing and most important thing in neuroanesthesia is you have to be very much vigilant throughout the procedure. You have to maintain whether it's a spine surgery, a cervical spine, even a lumbar spine, and even it is a brain surgery, you need to maintain hemodynamic stability in all the procedures during neurosurgical cases. There are various positions which we give for neuroanesthesia. This is a figure from your Miller, textbook of Miller. Once you give sitting position, the most, other than the cerebral ischemia, hypotension, then airway edema, the most important complication is venous air embolism in sitting position. In prone position, other than this complication, the most important complication is a eye compression causing blindness. Imagine a situation, a patient is undergoing prone position, surgery in a pose position. Let it be anything, an upper cervical spine surgery or a posterior fossa tumor excision or anything. And patient wakes up at the end of surgery and tells you that he is not able to see. Such a horrible situation. So this post-operative visual loss can occur if the patient is given prone, especially when your head is kept on a horseshoe and there might be eye compression which can cause this complication. So you have to be aware for such complication, and in your MD exams, a full question can be asked on post-operative visual loss, and a full chapter is there in textbook of Miller's of anesthesia on post-operative visual loss. So please go through that chapter. Then we can give, then there can be complications with lateral or three-quarter position, and also for CP angle tumors, many a times a park bench positions are given where you can get complications like venous air embolism. So you must know what are the complications associated with particular position, and you must be prepared for managing all such complications. As I said, this is a neurosurgical emergency. Intraoperatively, the patient might tell you that the surgeon might tell you that the brain is very tense, madam. Please do something. Relax the brain. I'm not able to operate. I'm not able to see anything inside. I'm not able to give Lasix, hyperventilate, give more propofol, do anything. But then you should have a checklist so that you can go properly to find out the exact cause for type brain. Is there any compression of venous drainage? Are the neck veins compressed? Is there kinking of endotracheal tube? Is there any bronchospasm, any pneumothorax, any venous air embolism? My patient is given prone position. Is there any compression of chest or abdomen? Is the patient in lighter planes of anesthesia? Is the patient, usually these patients are put Foley's catheter. So is there the drainage of urine is there, or is there the urinary retention? So these are the factors, along with the brain edema, these important factors we should not miss while checking for tight brain situation. And we need to give brief episodes of hyperventilation and give osmotic diuretics like mannitol, hypertonic saline. loop diuretics, steroids, give antihypertensive drugs if BP is not under control, increase the depth of anesthesia by giving more analgesia, sedation, and muscle relaxant. CSF drainage can be done if there is a lumbar drain inserted pre-operatively, and you can request the surgeon, you can decrease the brain bulk, and you can request the surgeon to go for operative decompression. There is something called as chemical brain retractor concept. This helps in decreasing the brain edema intraoperatively during the maintenance phase of anesthesia. You have to provide mild hyperosmolarity by using isotonic normal saline. Give 20% mannitol. Give hypertonic saline 2 to 4 ml per kg before bone flap removal. You continue increasing your depth of anesthesia with drugs like propofol, fentanyl, dexmedetomidine, remifentanil, whatever you are using. Give mild hyperventilation. Maintain normoxia, or you can give mild hyperoxygenation. Maintain normotension. Maintain normovolumia. And this along with head-up position, with proper taking care that there is no obstruction of endotracheal tube, no compression on neck veins, minimal positive end expiratory pressure, giving adequate depth of anesthesia. And if there is an external ventricular drain put by the surgeon, then CSF drainage by the surgeon himself. You can request the surgeon to drain the basal cisterns to get more space in the intracranial cavity. If there is a lumbar drain, you yourself can remove some CSF so that the brain bulk will be reduced. And at this same time, you have to also request the surgical team to avoid the surgical brain retractors. Because in a tight brain situation, if they try to introduce the surgical retractors, then it will cause cerebral ischemia to the tissues that is underneath the retractor, or it may damage important structures and it will increase the post-operative morbidity. So you provide the chemical brain retractor concept. So we need to know, again, I am coming to the same thing. We need to monitor the cerebral perfusion pressure and systemic hemodynamics by having an appropriate balance of cerebral blood flow, cerebral metabolic rate, and intracranial pressure. And all what is in our domain: anesthetic drugs, IV fluids, hypoxia, avoidance of hypoxia and hypercarbia, all these, and maintenance of mean arterial pressure. That will help us to have an appropriate balance between all these important factors. So what are the commonest causes of either hypertension or the hemodynamic instability in neurosurgical patient? Let's see. If suddenly your patients get hypertension in a neurosurgical patient, so patient might be having essential hypertension. Patient might be under light planes of anesthesia for laryngoscopy, intubation, incision, pin fixation. These are very important things in the beginning of surgery when you need to increase your depth of anesthesia by giving boluses of propofol, by giving additional opioids, and you need to control mean arterial pressure because sudden increase in mean arterial pressure during incision, during laryngoscopy, during pin fixation can be very hazardous to the patient. If the patient is undergoing BP shunt procedure, and when they insert the shunt in the abdomen by making a tunnel under the skin, that time also there can be a sudden rise in blood pressure. So you should be aware of this rise in blood pressure at that moment. If there is a hypercarbia, raised ICP, breast stem handling, and an emergence, if there is a coughing, all these conditions can cause hypertension in a neurosurgical condition in a patient. What are the conditions that can cause hypotension in a neurosurgical patient? First and foremost, hypovolemia. Then our anesthetic drugs like propofol, especially post-induction. What is neurogenic stunned myocardium? That is in a patients who have a severe bad head injury, a severe head injury with GCS less than 8. If he is taken for surgery, then he may need inotropic support for maintenance of mean arterial pressure. That is called as neurogenic stunned myocardium. He may develop hypotension intraoperatively, and you need to start inotropes for this patient. During positioning, especially sitting or even prone, if there is a massive air embolism, then handling of brainstem, trigeminal-cardiac reflex, and also these are the important factors which can lead to hypotension in a neurosurgical patient. So anything, the case is going smoothly and suddenly you get hypotension. You should find out the cause, and the cause can be one of these if your patient gets sudden hypotension during your case. What are the conditions that can cause bradycardia? As a part of pushing reflex, if there is a hypertension, patient might get bradycardia. There is intracranial hypertension during neuroendoscopic procedures, especially for V patients. If the V patients are done under neuroendoscopy, then the patients, when they enter the ventricle, fourth ventricle, then there is a chance that patients might get bradycardia. Brainstem handling during surgery. This is again very important thing. This is because you have to identify this. Your vigilance will identify this. And once you know that handling of brainstem is causing this kind of bradycardia or hypertension, you have to just request the surgeon to stop the handling. Usually, once that stimulus goes, that surgical stimulus goes, the bradycardia will get corrected itself. So this is very important, and you have to be vigilant for this, because if there is excessive brainstem handling also, I'm not going into details of intraoperative neuromonitoring in this, because we are learning the commonest challenges in neuroanesthesia in this class. So the commonest is what? You get bradycardia, and if it is a brainstem handling, if it is a posterior fossa, extradural hematoma, subdural hematoma, cerebellar bleed, or a posterior fossa tumor, and then you have to be very vigilant, because brainstem handling in such situations can cause bradycardia. As a part of trigeminocardiac reflex, and even during posterior fossa surgery, if there is vagus nerve stimulation, then also there can occur bradycardia. And the commonest causes of tachycardia, along with hypovolemia, sudden blood loss, pain, fever, hypercarbia, lighter planes of anesthesia, you need to identify as one of the important cause of tachycardia, cardiac arrhythmias, your drugs itself, then brainstem handling again. And the last and most important is unexplained tachycardia. You have ruled out all these causes, but then still there is tachycardia. The patient is anesthetized, paralyzed, sedated, you have increased the depth of anesthesia, but still the intravascular volume is good, but still there is tachycardia which cannot be explained. Then it can be because of the convulsions that the patient might getting intraoperatively. Such kind of cases, you need to be, if you cannot explain the tachycardia that occurs intraoperatively, then label it as there is a convulsive episode that's going on, because we are not monitoring EEG in such patients. So give top-up doses of anti-epileptic drugs, sedate the patients with midazolam. See to it that if there is no proper explanation for that tachycardia, you ventilate the patients post-operatively, let the patient get up on its own in another 6 to 8 hours. So you must be able to know why the patient is getting tachycardia, bradycardia, and why the patient has hypertension or hypotension. Dexmedetomidine has definitely made a very good, it is a very good drug as far as brain surgeries are concerned. And this is because it keeps the patient, it helps in maintaining the mean arterial pressure. That is what we want. We have to be very careful about hypotension and bradycardia. We are providing opioid sparing anesthesia. It is always, we always want the patient awake at the end of surgery to assess neurologically. So dexmedetomidine has definitely helped us for early neurological examination and stable hemodynamics. So we need to have individualized cerebral perfusion targets, maintain normoxia, normocapnia, normothermia, euglycemia, blood sugar control below 180, seizure prevention, precision ventilation to avoid any secondary brain injury for a good long-term neurological outcome. And this is what is called as neuroprotection intraoperatively. Then, as I said, the time of reversal has come and we need an awake patient. It should be always a well-planned procedure. We should decide intraoperatively only which patients you are going to make awake at the end of surgery and which patients you are going to electively ventilate in a neurocritical care setup. So planning of this should start right from, I will say, preoperative visit. Look at the scan, look at the big tumor, look at the big posterior fossa tumor with midline shift, mass effect, with the very significant brain edema. Such patients, handling can cause increase the brain edema. Look at the cortical venous thrombosis, big cortical venous thrombosis in a temporoparietal area, which may need craniotomy. So looking at the scan or the MRI preoperatively will tell you which patients can be extubated on the table. So whenever you want to have an early emergence from anesthesia, you need to have three homeostasis: a systemic homeostasis, a hemodynamic homeostasis, and brain homeostasis. The patient should be normovolemic, normothermic, normocarbic, with good hematocrit, normotensive, normal blood sugar levels, normal oxygen saturation, with normal cerebral blood rate, blood flow, and intracranial pressure. We should receive antiepileptic prophylaxis so that there should not be convulsions on table at the time of extubation. You must give adequate head-up position. Avoid coughing, tracheal suctioning, patient ventilator dysynchrony at the end to avoid any rise in intracranial patient. You have to extubate these patients in a deeper planes of anesthesia so that you avoid all pressure responses at the time of extubation. This is because, suppose you have removed a tumor, the surgeon has removed a tumor successfully, and at the end of the surgery, there is a big coughing of the patient, or you are suctioning the trachea, or if there is a patient ventilator dyspnea, there is a rise in blood pressure at the time of extubation, awake patient coughing on the tube. Whatever space that the tumor was occupying in the brain, the same space will be occupied by a blood clot. So again, this patient, if that becomes drowsy, will need a surgery for removal of blood clot. And that is why the depth of anesthesia should be adequate, where you should extubate the patients in deeper planes of anesthesia. So before attempting extubation in a neurosurgical patient, you must see few conditions. There are few conditions. If the patient is wide awake before you anesthetize them, so assess his preoperative state of consciousness. If there is a limited brain surgery, no major brain laceration, there was hemodynamic stability throughout, there was no excessive dissection or posterior fossa, the nerves were not handled much, no major AV malformation resection, there is normothermia, normoxia, and cardiovascular stability. You can plan extubation in such situations. And why you want extubation on table? This is because you need to evaluate this patient post-operatively. You need to assess these patients post-operatively, and we can diagnose the complications by doing the CT scan without any delay if the patient is awake. And even if, as I said, if there is a associated hematoma, he might need surgery. So therefore, neurological assessment is very important at the end of the surgery. There are certain challenges at the extubation also. I will not discuss all complications, but something like delayed emergence or something like post-operative visual loss. So a delayed awakening can be because of your residual drug effects, respiratory failure, electrolyte imbalance, hyperglycemia, hypothermia, hypotension, or if there is too much handling by the neurosurgeon, it may have led to cerebral hypoxemia. Patient might have got seizures, cerebral swelling, pneumocephalus, there might be thrombosis or embolism. So all these factors can cause delayed awakening. Already explained to you, post-operative visual loss, one of the dreadful complications of posterior fossa neurosurgery. Patient can get blindness because of external ocular injury, and the most important cause that has been labeled as ischemic optic neuropathy, retinal ischemia, cortical blindness. It is nothing but excessive pressure on the optic blood vessels which can cause this blindness. And if the surgery is of excessive duration, if there is a massive blood transfusion, if there is large intravascular fluid shifts, then also patient might develop postoperative visual loss. So you have to keep the eye shut by taping, avoid pressure on the eyes by headrest, avoid extreme neck rotations. You must have seen those mirrors that can be used to visualize the eyes. Avoid severe hypotension, hypoxia, avoid anemia, do not give excessive crystalloids as a replacement to blood loss, and prolonged head down position. And if there are complex spine surgeries, you can always stage them. And this is because these are done in prone position, and surgery for prolonged period, this complication is known. So you have to be aware of this post-operative neurological, post-operative visual loss. So the take-home message for today's lecture: the main objective of anesthesia for any neurosurgical intervention is control of intracranial pressure, avoid brain swelling, maintain cerebral perfusion pressure, avoid hypertension as well as hypotension, avoid impending brain herniation. You have to act fast. If you feel that patient is becoming drowsy, if you feel in the neurocritical care that this patient needs emergency intubation, don't wait. And if you put a tube, put the patient on ventilator. So this is also very important. You have to have a basic knowledge of neurophysiology, pathophysiology, and pharmacology. And if you know everything, the basics of this, then there will be good patient outcome. And thank you very much again for giving me this opportunity to share with the commonest complications that you see during a neuroanesthesia procedure. Thank you so much.
Thank you, ma'am, for this comprehensive lecture, and all aspects of neuroanesthesia have been covered in a very lucid way. And a lot of questions can be expected from neuroanesthesia in theory as well as in the viva voce.
Yeah.
So you have covered very well, ma'am. So all the postgraduates, I request you to put forward any doubts that you have in the chat box, please.
Only, madam. Yes,
Sorry.
permission from you and Janaki Babu, sir, regarding the lecture. First, I want to compliment Dr. Manisha, madam. It was an excellent lecture. What we all face in the practical experience, he told it in a nutshell. But
Yes.
we have faced many issues. We
Very
never had an acronym there. We used to use only dextromethonium or else only thiopentone. Propofol is also like it is very costly drug at the time when we are practicing right now.
It's
So madam has excellently explained everything. Now with all the gadgets and whatever we have, it's really very beautiful way. And madam has put everything in nutshell. It's very complicated cases we do.
Yes, sir. Yeah.
And at that times we never had a EMD, a separate department, madam.
Yes,
We
sir.
were only looking after EMD.
Yeah.
So whatever case used to come to EMD, we used to wheel it into the OTs.
Sir.
That was a really challenging issue for us.
Yes,
When we were all postgraduates and all, when we were practicing early time, really that is like now the postgraduates don't know that how we faced, what we had, all these things
Sir.
now.
Very true, sir. Very true. Very true.
At that time, we never had anything like any miracle dexmedetomidine, everything. We never had all these things now, ma'am.
Sir. Very true.
No.
We have learned
So
from basics, sir. We never had all these monitors, these gadgets and anything. We have learned from basics, sir.
ground level to the top
Yes,
most,
sir.
ma'am.
Sir.
Very
And
nice.
ma'am,
Yes, ma'am.
Sir.
Please.
and ma'am, we used to use the sitting posture, ma'am.
Yes, ma'am.
No,
Yes.
it is not being used now. You are using the prone posture.
Yeah,
So
yes.
venous air embolism was very common then.
Common. Yes,
Yeah.
ma'am.
We used to put a
So
central line, we used to advance it and again pull out. That was really very
Yes.
that
Yes,
is
sir.
complication.
Sir, in fact, even madam, to give sitting position, it is so difficult many a times. Like used to get hypotension. Like so,
Yes, ma'am.
what my teachers had told me that time. I did my post graduation diploma in anesthesia from JJ Hospital and then MD from Tata Hospital. So during that my DA, the teacher used to give 5-degree elevation and then check blood pressure.
Yes,
Again
ma'am.
5-degree elevation.
Yes,
Yes,
ma'am.
ma'am.
The positioning itself used to take around half an hour, ma'am.
Yes,
Was
ma'am.
Yes,
sitting
ma'am. That's
position.
true. That's true.
Yeah.
And one more thing is
So-
that I worked my whole entire career in only peripheral centers only, ma'am. Not in the
Okay,
centers
sir.
like where you worked. Manisha madam is working in Mumbai and all. That is a very great center
Yeah.
where they get limited
I was-
supply of drug center.
Yes.
So Janaki Babu sir knows all this because sir also worked along with me. Sir
Yeah.
knows.
Madam, good evening, madam. Good evening, madam.
Good evening, sir.
Thank you.
Good evening.
Yeah, yeah.
Good evening.
Madam, in a setup like where government setups where we don't have the many monitorings, and especially emergency craniotomy in the trauma centers, what minimum gadgets and minimum monitoring do you suggest for the postgraduates?
Sir, we should have only 4 monitors for, I will say, any neurosurgical case. ECG,
Please
pulse
suggest, ma'am. Please.
oximetry,
Yes, ma'am.
end-tidal CO2, and NIV.
Very great
Okay.
suggestion, madam.
Yeah.
It's very good. Yes.
Yeah.
And our
Even-
hand on the pulse, ma'am.
That is
That
the
is the
first
best,
monitor.
ma'am.
That is the first monitor, ma'am.
Pavani madam, that is the best because every time my hand goes onto the pulse only.
Yes, that is the first
Yes, sir.
monitor. But these 4 monitors will help us to detect many complications intraoperatively. We should have ETCO2, end-tidal CO2 for doing neurosurgical cases.
Yes,
Yes.
ma'am. That is true. That is true.
Yeah.
Madam,
And
can I
please,
ask a question, ma'am?
ma'am.
Recently, yeah, we are going for TIVA, ma'am. So, role of TIVA in neurosurgery, ma'am.
Yeah. Madam, TIVA itself is because this I said we have to avoid increase